All right, well, we're going to dive into some pediatrics this morning. Everybody ready for a little peds?
Ready for
We've got
peds.
3 segments of peds before the break. And we're going to kick it off with paper number 79. So I think this is on page 86, 87 in the hymnal. The first paper here is actually, we're starting out strong. I like this first paper a lot. I think it's a really interesting paper. The question here is, how often do babies, it says young children, but it's really babies, get viral infections? We know it's a lot. I think everybody knows that. But can you quantify it? So this was a really creative study funded by the CDC in Cincinnati, where they basically took 245 mother-infant pairs when they were born, gave them a bunch of swabs, and said, here, swab your baby every week and send it to us, and then we're going to text you and we're going to ask you if your baby's sick for 2 years. And we're going to get an idea of how often these babies are getting infected with viruses and how often they actually manifest symptoms, which is a really interesting question. I don't think we know the answer to this. And it came out with some really interesting numbers as well. So basically they found that viruses were present 9.4, let's say 10 times per year, 10 viruses a year, those swabs were positive. And of those 10 a year, they were sick about 3 times. So 10 viruses a year, sick 3 times, symptomatic 3 times. And it was pretty rare for them to actually go to the ED or get hospitalized, only 4%. So what does that tell us? That tells us, 10 viruses a year, about 1/3 of the time they were symptomatic, so 2/3 of the time they were asymptomatic. So they're getting exposed to a lot of viruses in their first couple years of life. And this correlates with what I remember when I was a junior learner. I learned from one of my pediatric mentors who said, Jan, these kids don't have jobs, clearly, but kids do have a job. Their job is to get sick. Their job is to get sick and make antibodies. That's what they're supposed to be doing, which always stayed with me because that seems very true, and this paper kind of proves it. In terms of which illnesses caused more symptoms, obviously RSV was up on the top of the list. Longer illnesses with RSV, really common to see rhinoviruses and enteroviruses. Those were half of the infections, so it's really common. I think this is good advice to give parents that come in with little kids with viruses, like how often they're actually being exposed, and what a terrific methodology to give us some really useful information.
It's really cool. And this was done 2017, 2020, so right before COVID, where kids were still building up immunity and antibodies. And I don't know if anybody has young kids or grandkids or nephews or nieces, but now it feels like that 3.3 feels like, this is anecdotal again, but feels like it's shot up. My kids are sick all the time, and I wonder if it's because we didn't get that exposure to those 8 or 9 viruses during that time. And this is, you're right, this is great info for parents, because Lolly, my wife, would always tell me, she's like, do our kids have some immunodeficiency that they're getting sick like this all the time? Do we need to get them tested? And this is good. This is good information to pass on to the parents. And this kind of plays in really nicely to abstract number 80, clinical characteristics of different respiratory pathogens. So this next paper is a secondary analysis of an RCT that was done of kids that were getting swabbed. About 1,000 kids, they got swabbed. The initial study was looking at swabbing all these kids that presented with influenza-like illnesses. So they present with URI-type symptoms, and they all got swabbed. They got randomized into the doctors knowing or not knowing about the swab results. And they wanted to see what the impact was on antibiotic prescribing habits. They found that there was no difference, whether they knew about the viral panel results or they didn't know about the viral panel results. That was the original study. So it still begs the question of, now that we have access to these like biofires and PCRs, and we're able to like tell exactly what type of viruses the child has, does that make any impact on our practice? And the answer to the initial RCT was no. But the secondary analysis dove in a little bit more into some of the stuff that Jan was just talking about, which was, based on the type of virus that they had, what were the clinical characteristics of those viruses? And what they found was there was a 2 times increase in rate of hospitalization based on certain viral pathogens. And those were the human metapneumovirus, RSV, and some of the atypicals. So Jan mentioned RSV. RSV was also associated with lasting longer. You get those like viral illnesses that after 5 days, you're like, all right, it should go away in a couple days. And then after 10 days, you're like, gosh, I can't kick this thing. They found that those viral illnesses tended to be either RSV, parainfluenza. So not much to do with this information, but it is interesting. Some of the other things that they found, if you had GI associations, we know that it's more likely to be adeno. 85% only had one virus, but 25% had multiple viral pathogens identified at one time. So very interesting stuff, but will it change our clinical practice?
I don't know, post-COVID, I think, a lot of us have more access to viral swabs than we used to. I remember, we used to not really have any viral, they're expensive. We didn't used to have a lot of viral swabs. We had an RSV swab for babies, but now we have like a COVID, flu, RSV trio panel. But a lot of places have access to even more expanded respiratory virus panels. How many of you have access to one of those like expanded panels? Okay, so like half the crowd maybe, but others don't. We don't have an expanded one, but we have this like basic one, But it's interesting to see like how people use that information when they choose to test and not test, et cetera. Let's keep talking a little bit about peds infections. Yeah, go ahead, sorry.
Yeah.
It's like $500, right? It's a lot of money. I mean, that's a lot of resources to consume. However, now that post-COVID, what I'm finding is that, parents know about these viruses, right? They want the test.
Do I have RSV? Does it matter?
Yeah, does it matter? Is the positive test, we know also that that may not be what's causing the infection that they're with right now, we don't even know sometimes how to exactly interpret that information, but people want that information, and it can be useful. I don't mean to poo-poo that it's not useful to figure out why a kid has a fever. It can be useful. But I think it's sort of new, a little bit of new ground. I mean, swabs have always been around. We've always had quickie flu tests for a long time. And as we went into the era of antibiotic stewardship, which has been a while now, swabs became interesting because maybe that would be a way we could decrease antibiotic prescribing. We find in some of these studies, we're going to look at some more, variable results in terms of how practitioners behave when they have those results. Sometimes people are going to give antibiotics no matter what the result shows. So let's look at the next paper here, 81, which is about pneumonia, and is short course antibiotics for pediatric pneumonia safe. So the shorter is better literature in general in adults as well. Less antibiotics, shorter courses is very hot right now. Lots of shorter is better in lots of different conditions, not just UTI, which we kind of know in most uncomplicated UTIs, but in lots of other conditions. This is about pediatric pneumonia. Now we can start, before we get into whether shorter is better, the question is, what does pediatric pneumonia mean? How do you diagnose pediatric pneumonia? And is most pediatric pneumonia actually just a viral infection that we decide to call pneumonia because we want to give antibiotics?
Yes.
Or a parent wants us to give antibiotics. But in terms of official guidelines, you don't need a chest x-ray to diagnose pediatric pneumonia. That's what most guidelines say, although some studies include chest x-rays, some don't. What's the literature on the short course antibiotic situation? Well, there's two studies that precede the one we're going to look at here. Back in 2021, there was the SAFER trial. The SAFER trial looked at 5 days versus 10 days of high-dose amoxicillin. This was in Canada, almost 300 kids. 5 days was superior. And then in 2022, there was another study, the SCOUT-CAP trial, also 5 days versus 10 days, 300 kids, 5 days also won there. And so paper number 81 is a Chinese group that did a meta-analysis. So they take all the trials that are out there on this whole short course question, 16 different trials. That's a lot of data. 12,000 kids at this point have been put through trials looking at shorter courses of antibiotics. These are all RCTs. There's a variability in terms of what do I mean by short course. It could be anywhere between 3 and 5 days, so a little bit of variability in terms of design. And so these 16 trials, the primary endpoint was, did the kid get better? Which, of course, in most cases of pediatric pneumonia, kids are going to get better. And so in the end, clinical cure was the same. It didn't matter whether you had short course versus long course. So this meta-analysis bears out the same results as what we've seen in the last few years of these shorter is better. It's a lot of data. But I think, again, I would back up to say, what if you were to randomize them to short course, long course, or no antibiotics, which often is not what's being tested, but I think would also probably pan out to be probably fine. But that's just hard to swallow, that we're going to call something pneumonia or think that somebody has pneumonia and not give them antibiotics. But theoretically, the question would be, what if you did no antibiotics? It doesn't matter if it's 3 days, 5 days, 10 days. It begs the question, does it matter if you need it at all? But certainly if you're going to choose to do antibiotics for pediatric pneumonia, shorter course just as good. You don't need to give the 10 days that you were sort of trained to use.
Yeah, and I like this trend toward shorter courses. And my approach now is to do the shorter course, get them to follow up at that time frame, assess, make sure they're improved and they're good, and then the PMD can choose to extend longer if needed.
Oh, interesting. Other point about antibiotics is that obviously when we talk about antibiotics in kids, there's adverse effects, right? There's diarrhea that comes as a price to pay for the antibiotics. But they found that adverse events were not really different between the groups of shorter versus longer antibiotics, which is interesting because I think the concept there is that if you start the antibiotics at all, you're going to get some diarrhea and some adverse events. It didn't matter necessarily that you went longer or shorter. It doesn't save you the diarrhea or the adverse effects to go shorter. So that's also a good take-home point there.
Abstract number 82 is about bronchiolitis. And specifically, the question is about whether nebulized hypertonic saline has a role in treating bronchiolitis. We know bronchiolitis is common. We see it, the RSVs, all those cases. And it's one of those disease states that we don't have that many interventions for.
Yeah, nothing works in bronchiolitis.
Yeah.
I mean, yeah.
What is it? Suction, oxygen maybe, observation. Anybody using hypertonic saline in their ED for bronchiolitis? Okay. So this might be an interesting paper. Here's an option. So this is a Cochrane review, a systematic review meta-analysis looking at nebulized hypertonic saline, which theoretically would help to decrease your airway edema and mucus plugging. It's a update to a prior Cochrane review. They looked at 34 trials, about 5,000 infants, and specifically they looked at primary endpoints of whether or not the hypertonic saline would help to decrease hospital admissions or length of stay. And I'll tell you, bottom line, without getting into the numbers, was that they found that there was a benefit, but it was very, very small. It was very small, very marginal, and the evidence was very weak. So here are the numbers. The relative risk of hospital admits was 0.9. The relative risk of hospital length of stay was 0.9. And the fragility of these numbers was very, like you crossed over a few studies or patients, it didn't make that much of a difference. So in their conclusion, they basically talk about hypertonic saline being an option if you want to give it, but it is very, very marginal in its benefit. Like the length of stay, for example, was a decrease of length of stay of 0.4 days. So that's like a morning instead of an afternoon, type of thing. Possible. I don't think that this is going to be a game changer, but you may be seeing it in your EDs. This Cochrane review may be gaining some traction in the peds world, and in your admitting patients, they may be starting hypertonic saline. If you have a really sick one, maybe something to throw out there, but it's not super convincing evidence.
You've got a kid with bronchiolitis, you feel like you need to do something. I mean, you can't just, you're admitting a kid for bronchiolitis, what are we just going to do nothing for them? And often at the beginning of the story, you may not know exactly what they have, right? We don't know, these are stories often from looking at from the pediatrics, they're admitted with bronchiolitis. By that time, they have the RSV, by that time, they have lots of other results and the power of observation. We're starting at the beginning of the story with a kid who rolls in with some wheezing and some, looks kind of sick. We don't necessarily know right at the get-go. We may have our suspicions, so you're going to do something. So a lot of people are going to normally start some albuterol, do some things. This is just sort of on the list of things that they might do upstairs.
It kind
of reminds me of with, sinusitis, we do if you've ever had sinusitis, you do those like neti rinses or sinus rinses with saline, does the saline sort of suck the goo out and help expel it? I don't know, maybe. I can see why it might be a theoretical benefit to get it down there and sort of, do the osmotic diuresis of the phlegm, but interesting. Okay, that's interesting. I don't use hypertonic saline as a nebulizer, but it's something to try. What about croup and cold air? This is paper number 83. A lot of people feel like when kids get croupy, if they go outside with cold air, anecdotally it seems to work. Here's actually a pretty good trial this is in Switzerland, randomizing children who have croup to have cold air exposure versus not, to see if it actually helps. This is in an academic PEDS ED. They all got Dex, so we know that in croup, dexamethasone is kind of a standard. administered. So all these kids get steroids, and then they randomize them to, you go out and stand outside in the cold air, right outside where we can see you, and these ones are not going to, and we're going to see sort of how they do, which is pretty clever.
I love it.
Low cost, like interesting question. It's a good clinical question that we're actually studying in a randomized way, not just anecdotally. So they went outside of triage with blankets. Now this is in Switzerland. And it was quite cold there. It was like 10 degrees. So it was really cold. That's not necessarily what some of you might live in climates where it's 10 degrees. It's pretty cold. So, and whether the degree of cold, does that matter? I can't answer that question for you. But in the cold Swiss air, it seemed to make a difference. So for about half of the kids who went outside felt better versus a quarter of the kids were inside, showing an improvement at 30 minutes was their outcome. And most of the secondary endpoints they looked at were all similar, and no adverse events occurred. Nothing bad happened. Nobody got frostbite out there. And so they said 30 minutes of cold outdoor air could probably help. And here's an objective randomized trial saying that that's true, which a lot of parents have kind of suspected for a long time.
Right on their back.
What if you just pour a pitcher of ice water down them? Yeah, that might make the difference.
If you get parainfluenza, you will feel better faster.
Yeah.
I like this a lot. It's like use your natural environment. We can't do it in LA. In Hilton Head, it's not going to work. I don't know if I would tell my kid to like stick his head in a fridge for a little bit and see if he feels better. I don't know how I would apply this, but it's neat. Low cost, no cost.
Yeah, you live somewhere cold. That's nice. You could do this.
Abstract number 14 is also about croup, and it's about the use of an epinephrine MDI, meter dose inhaler, instead of using nebulized inhaler. So when you get your croup kid, we talked about even if they're mild, you're giving the steroids, and then once they get to that moderate to severe category, you start to throw on the epinephrine, nebulized, and you see if they improve. The authors of this paper out of Canada, they just basically described their experience during COVID. They didn't want to use the nebulizers and get that nebulized air everywhere. So they reached out to the Primatene manufacturer, the folks that make the epi, and they asked, would you guys be able to provide this in the MDI form? They sent it to them, and they described their use of those MDIs with 200 patients, and they found that their croup scores went from 3.9 to 1.7. This isn't a trial, there's no comparator. This is basically a letter to the medical world saying, hey, if you don't have a nebulizer or don't want to use a nebulizer, an MDI is safe. Now, most kids, the applicability, most kids that get croup are less than 6 years old. Are they going to be able to use MDIs versus nebulizer? Nebulizer is probably easier, but it gives you one more option in your toolbox.
Well, Primatene Mist has been like, you can find that on the shelf at your
OTC.
Local pharmacy for like forever. I mean, Primatene Mist has been, kind of an old school on the shelf, sort of marketed towards asthma and respiratory stuff forever. So at least, parents could buy this. They could try this. It's something you can just get.
Yep.
It's not too expensive. It's been around for forever. I mean, I feel like I've seen Primatene Mist on the shelves for a long, long time. So Primatene Mist for croup, that's kind of an interesting one, yeah. Agree with you, though. MDIs are hard for little kids to use. Yes? Right. The comment is, if cold air works for croup, we also tell people to go and turn the shower on and make some steam, and that seems to help too. Yeah, and that does anecdotally also help, and that the steam helps also, what's the word I'm looking for? Not liquidize, but humidify and moisturize the upper airways to kind of get things out. That's sort of, I think, the idea behind the steam. So multiple things might be working here, right? That there's certain different mechanisms can do different things. But it's a good point. Number 85 is about magnesium and asthma. My goodness. How many times have we talked about magnesium asthma? A lot. That's because the question sort of rages on whether magnesium really makes a difference. And this is in pediatric asthma. The question here is, does the timing of the magnesium, is that the thing that might be making the difference? Does early mag reduce PICU admissions in pediatric asthma? Pediatric asthma is complicated. Obviously, if you're giving magnesium to your pediatric asthma patient, that pediatric asthma patient is probably pretty sick. right? That's like that's in your kitchen sink of like, they didn't respond to my initial stuff. I'm now reaching for the magnesium. This was once the rage in pediatric asthma, as it's kind of like gained favor and lost favor. Now it's not so clear after some recent trials. So this paper, which was published in Peds Emergency Care, is also not going to give us a definitive answer, but it's looking at the timing. Does the timing of when you give the IV mag make a difference? And it will decrease, that's not about patient outcomes. It's about, do I decrease the chance that you're going to be admitted to the PICU? Does it maybe make a difference there? So it's about timing and an outcome that's about admission to the PICU, not a clinical outcome. So I'll start with those things. They found that basically they looked at charts. This is not like enrolled people and randomized them to MAG or NORMAG. They looked at 1,900 charts, 2 years of data of pediatric asthma and an ED, looking at associations between kids that got IV magnesium, the time to administration, and what are the chances they ended up going to the PICU. This is not a great study, no chart review methods, and they found on their multivariate regression that giving IV mag was associated with them going to the PICU. Not a surprise, because like I said, it's the sicker kids that are getting the IV mag, so those are the kids who are going to go to the PICU. And they did find that it felt like they did not find that it really made any difference in terms of fewer PICU admissions, which is also not a shock. So the bottom line, the timing of the IV mag, whether they got it early, late, or not at all, not associated with admission to the PICU. And again, like this is to me sort of like, duh. Again, this is Journal of Duh. The sicker kids get the magnesium. Whether they go to the PICU or not, I don't think it matters about the magnesium itself. That has nothing to do with the magnesium. It has to do with the disease process. How sick they are. And it's not going to stop me from giving magnesium either, because I didn't have a clinical outcome here that tells me whether to give or not to give is going to make a difference. So I'd still give the magnesium. I just don't, the timing probably doesn't matter, which is sort of intuitive.
Yeah, and like the hypothesis would be that by giving MAG, you would help decrease PICU admissions, but you could also argue the flip side, that if you're the admitting doc and you're seeing that, oh man, this kid got magnesium, maybe it makes me feel like I should get this person to a higher level of care, and it could be biasing that way.
Right, true.
And the magnesium is chopped, like that literature has chopped up and back and forth, where it's shown benefit and not shown benefit, and we don't really know what to do. And the spectrum bias part of it, like in the sickest patients, do you give it?
Yeah, I mean, if I have a sick asthma kid that's going to go to the PICU, I'm going to be doing all the things. I'm going to be doing the steroids and the nebs and all, I'm going to add magnesium to that as well. And actually, to answer this question, you would really need a randomized control trial where you have sick kids with asthma that you're going to give MAG or not give MAG and see if they do better or worse. That's just going to be a little hard to do because magnesium is such a part of our standard of care, and there are papers to say that it has benefit. It's going to be hard to find an IRB that's going to allow you to just not give a therapy that might be beneficial to a really sick kid. Not to mention, it's very difficult. One of the things about all the asthma literature is a spectrum bias of publication. It's hard when somebody is a very sick asthmatic patient to enroll them in a trial because they're very sick. Now, you have parents that you can enroll here, but you always find that in the asthma literature, there's a bias towards the not so sick asthma patient rather than the really sick asthma patients. They're harder to study. There's not as many of them, and they're harder to enroll in trials.
Yeah, you're consenting the parents when the kid's like sitting there. It's hard to justify. The moderate to severe trials have been, there's some positives, some negatives, but like those, it's hard to know, like does ketamine help, does MAG help, because those status asthmaticus patients, we don't have.
It's not a well-studied area.
Yeah. All right. Was that?
86?
One more.
When we got one more.
86 is high flow nasal cannula versus standard O2 for acute hypoxemic respiratory failure. This is the Paris 2 randomized controlled trial. This is potentially a practice changer. How many folks are using high flow nasal cannula for your sick hypoxemic patients? Yeah.
Much more than we used to.
Yeah, definitely much more than we used to. I think post-COVID it's become much more standard. And so in this paper, they kind of look back and said, well, in 2015, there was a trial of hypoxemic respiratory failure in adults that showed a decrease in mechanical ventilation. 2018, in children, there was a paper that showed less elevation of care, but there was no change in length of stay or ICU admissions. So in light of that data, they wanted to kind of make that data more robust. This was published in JAMA. They did an RCT of about 1,500 kids in New Zealand and Australia, aged 1 through 4. And all of these kids had moderate respiratory failure, meaning they had to have a respiratory rate greater than 33, they were breathing pretty fast, and they had to have an SpO2 less than 92%. So, and these kids weren't the sickest of the sick either. So these weren't kids where you immediately looked at them and you're like, I need to send this kid to the ICU. They excluded all the ICU patients. These were kids that you wanted to admit because their oxygenation was low and they were having trouble breathing. They wanted to see in that subset of kids, if you put them on high flow nasal cannula versus putting them on standard nasal cannula, would it help to prevent ICU admissions? Would it help to decrease length of stay? And here are their findings. They found, in an interesting way, these results may sound surprising to you. They were to me initially. They found that in the high flow nasal cannula group, the length of stay was increased, 1.8 days versus 1.5 days in the standard O2. ICU admissions were 12.5% in the high flow nasal cannula group versus 6.9% in the standard O2 group. And the high flow nasal cannula group had higher escalation of care. 4 of those patients got intubated versus 0 patients in the standard O2 group. And these were randomized. This wasn't just, there isn't that sort of like association bias where, of course, the sicker patients got high flow and got intubated. This was a randomized controlled trial. There was some crossover in this trial. Kids that got started on the high flow nasal cannula, a lot of them didn't tolerate it, so they crossed over to the standard O2 group, so that caused a little bit of an issue with the results. But overall, the conclusion was that high flow nasal cannula, as a matter of routine, in patients that aren't immediately going to the ICU, should not be done routinely. And I think that there's some things to tease out of this study. One is the high flow nasal the authors felt that perhaps the RTs and stuff weren't as familiar or comfortable with the weaning protocols, taking patients off high flow nasal cannula after they improved, and maybe that increased their length of stay or increased their chance of going to the ICU. But it didn't seem to decrease escalation of care or any of the metrics that they were interested in.
Well, this is not blinded. And when you see a kid, if you saw a kid that was on high flow versus standard oxygen, which kid would you think is sicker? The kid on the high flow. You'd look at the kid on the high flow and say, well, this kid must be sicker because he's on high flow, and this kid must be less sick. So you could have randomized them, but honestly, I think looking at a child on a device that's different than another device, it's probably harder to wean, and probably if I were upstairs and I had a kid on high flow and a kid on standard oxygen, that kid on high flow, as I wean them, I may be more conservative about keeping them in the hospital a little bit longer. They must have been a little bit sicker. It's just, I do think that there's a difference. Even though we randomize them, there's a device bias that one is going to be perceived as sicker, and probably going to be the de-escalation of care will be a little slower than somebody who's on standard oxygen that now you're better, you can just go home. So I think that there is a difference there as they get upstairs and you perceive their device and what they're on and how sick they must have been at the beginning.
And the comfort of the nurses on the floor that are like, wait, why am I getting all these high flow patients now? Get them somewhere else. But so my takeaway from this is that the patients that are very, very sick, that you're trying to avoid mechanical ventilation, you're trying to avoid intubating, and that you were otherwise potentially going to put on BiPAP or CPAP, and you don't think that they're going to tolerate it, I think high flow nasal cannula still is a option. As a matter of routine, though, I am not just sticking high flow nasal cannula. I would start with the standard O2 and kind of escalate care as needed.
Yeah. I mean, in some places you might have protocols where someone who's on high flow has to go to an ICU or a step-down unit and can't go to a regular floor. So it does sort of, beg the question of what level of care do they really need and how sick are they? If you put them on high flow, they must have been pretty sick. So, all right. Do you want to do a quick little sentence?
Yeah, let's do it.
All right, first one. Between ages 0 and 2, viral infections are very common. On average, they're symptomatic about 3 times a year. But if you were to swab them, they're actually getting exposed to about 10 viruses a year.
Abstract 80, human metapneumovirus, RSV, and atypicals cause higher rates of hospitalization. RSV and parainfluenza cause longer duration of illness.
For kids that you're diagnosing with pneumonia, you're sending them home with antibiotics. Shorter is better. 5 days for sure, maybe even 3 days, maybe even no days, versus 10 days is out.
Nebulized hypertonic saline for bronchiolitis may have a mild effect on decreasing length of stay hospitalization, but very marginal and based on weak evidence.
Kids with croup, don't forget the Dex, but cold air may also relieve their symptoms.
Epinephrine, MDI, primatine made a comeback during COVID, but I don't know if it has a use beyond that for croup kids.
IV magnesium in peds asthma is taking another shot here with this paper. Based on some flawed data, you might be able to say that timing has maybe a marginal difference, but really it doesn't matter when you give it, and you can still give it.
High flow nasal cannula versus standard O2 in patients that are not going to the ICU and have acute respiratory failure. We can start with standard O2 and escalate care as needed, but high flow nasal cannula may still have a role in the sicker patients that you're considering intubation or mechanical ventilation.
All right.